Hello and welcome to The Print. You are watching Health and You, and I'm Sumi Sukanya Datta. The launch of Mounjaro in India recently, which has tirzepatide as an active pharmaceutical ingredient to treat obesity and diabetes, was one of the biggest news in months. The drug, like semaglutide, was first developed as a treatment for diabetes, but by its mechanism of action, it is very effective against obesity as well. It has emerged as a blockbuster medicine worldwide. In a country where a significant population is now overweight and obese, this is the first drug launched exclusively for obesity. But who can use it? How does it work? And how safe is it? To discuss these very important points, we have two very important and eminent guests, Dr. Anup Mishra and Dr. V. Mohan. Dr. Mishra is Executive Chairman and Director of Diabetes and Endocrinology at Fortis CDOC Hospital, and Dr. Mohan is Chairman, Madras Diabetes Research Foundation. Welcome, Dr. Mishra and Dr. Mohan, on this
Thank
show.
you. Thank you.
Dr. Mishra, how significant do you think the launch of tirzepatide in India is?
Um, we actually have had several drugs before this, which are of the similar line. They are sister drugs, and they have been available for last 2 decades now in India. Uh, so we have good experience of the sister drugs, which are of lesser potency.
Mhm.
But they were primarily for diabetes, and in addition, the weight loss was an added bonus. Uh, However, this particular drug, which is shown very impressive results in people with obesity without diabetes, now has opened a new horizon in this area and given us a very potent weapon to treat obesity. So, from that angle, it is a very significant event that tirzepatide has been introduced in India.
Okay. So, what kind of people can actually use? Like you said, there would be some patients who don't have diabetes, but they are overweight or obese. Can all of them actually use tirzepatide and other similar drugs once they are available in the market?
No, that's never our approach. Now,
Hmm.
suppose somebody is obese and BMI, body mass index, is something like 35, clearly obese, of almost highest degree of obesity. Uh, we, if this person can do diet, exercise, and if he does not have diabetes, if this leads to, without any drugs, if it leads to significant weight loss, and some people do that in 2 to 3 months or 4 months, then we can continue like that without using the drug. However, if this person has significant symptoms, even if a person doesn't have diabetes, has the symptoms of shortness of breath due to obesity itself, or palpitation on daily, whatever walking he's doing at home, and also knee pain or low back pain. These are some of the characteristics when we put obesity according to our new classification in stage 2. And once this is there and patient is unable to do enough exercise because of some of the mechanical problem itself, or is non-compliant to diet, uh, or patient says, doc, you give me any drug, but I can't do this, where I have tried, or something like that, then we certainly would like to start this patient on tirzepatide. Uh, so first, if patient can do, we must exhaust the conventional ways of losing weight. And if a patient has diabetes, there are other drugs also with which a patient can lose weight. If significant weight is not being lost, patient is symptomatic, patient is stage 2 diabetes, then we should use tirzepatide.
Okay. Thank you so much for that information. Dr. Mohan, we would like to draw you in the conversation now. So please, can you simplify, because this class of drugs belongs to GLP-1 or dual agonists, as we call them. So can you simplify for our viewers what exactly is the way these drugs function? And how are they beneficial as compared to traditional medicines for type 2 diabetes, or how are they actually effective against obesity?
Yeah, thank you, Sumi. So, in the gut, the intestine, we have several hormones which are actually friendly to the metabolism. They help to increase the insulin secretion, and they block another hormone called as glucagon, which actually increases the sugar. And these hormones are called as the incretin hormones. Actually, several hormones, and two of them, one is called the glucagon-like peptide, or the GLP, and the other is the gastric inhibitory peptide, or the GIP. Now, as Dr. Mishra said earlier, we have had many drugs of the GLP-1 agonist class. You may ask, why don't you just give GLP itself? Why do you need these drugs? Now, the problem is that GLP has a very short half-life, only a few minutes, so it doesn't work. There are drugs which try to stimulate the action of the GLP, and therefore they are called as GLP-1 receptor agonists, which means they help the action of the GLP. So those drugs we have had for over 2 decades, as Dr. Mishra said. And one of those drugs which became very popular recently, one of the most powerful drugs, is called semaglutide, otherwise known as Ozempic or Wegovy. And that is produced by another company. And that has become a runaway success in the US. Now, Lilly went one step further and produced a drug which uses two of these hormones, not just the GLP, but also the GLP and the GIP, both this agonist for both of these hormones. Now, when you have two of these hormones being used simultaneously, then the effect is even more. And what has been shown in clinical trials is that tirzepatide, or Mounjaro as the drug is called, produces far more weight loss than with the individual single drug that is the GLP-1 alone. If semaglutide itself was a big breakthrough because the kind of weight loss that semaglutide achieved compared to the other GLP-1 analogs was kind of unprecedented. We had not seen that. But then Mounjaro or tirzepatide went a step further because the GIP is also being stimulated. Now, the advantage of both the hormones being stimulated is, number one, of course, the effect is more in terms of weight loss. It is more in terms of the reduction in the HbA1c, or 3 months diabetes control. Also, it is more. So head-to-head, some trials have been done where actually it outperforms the semaglutide. So obviously, because two drugs are being, so you may ask, why not use more than two? In fact, there are drugs being developed with 3 hormones now being stimulated, glucagon itself being added on. There's a drug called retatrutide, and this company is also into that. In fact, there are about 20 or 30 different companies which are trying all kinds of permutations and combinations, because this particular class of agent, the GLP, GIP, we call it as the single hormone, dual hormone, triple hormone agonists, and so on. They've taken the world by storm, and I don't think we've seen the last of this. But the semaglutide has come only in the oral form to India. We are expecting the injectable form to come in, but Mounjaro or tirzepatide has already been introduced in the country. In fact, even before the drug came in, I never used to encourage people to bring it from abroad, but many used to just go and get the drug because they have heard so much about it. And already we have seen some patients lose weight and so on. And now that it's officially available, we have started using it. So for people who do have, as Dr. Mishra said, when the diet and exercise, the lifestyle modification does not work, and in many people, even in some people it doesn't work at all, and in some people it works partially. I mean, you can't, very rarely you will get 20 kg weight loss with the lifestyle modification. And even if you get it, they don't sustain it. This kind of yo-yo effect you will see. It will come down, go up, come down, go up, which is bad for the body because the weight keeps on shifting like that. Now, with drugs like this, the weight loss of a type which is seen only with, say, bariatric surgery is now being achieved by a weekly injection. So in that sense, we are all quite excited that we have drugs now for those who need it. Not everybody needs it, but for those who need it, we certainly have
a number of how many obesity affected people might actually need it. Is there can we have a rough idea on the percentage?
As Dr. Mishra said, you can measure obesity by several methods, and he has written several classic papers, including in the Lancet, where the classification of diabetes itself has now been changed. So in mild degrees of obesity, let's take BMI itself, which everybody knows about. You can also use waist or waist by height, and many parameters to measure central obesity or generalized obesity. But if you take the old, BMI, which everybody talks about, up to 23, it's normal. And then from 23 to 25, it's probably overweight, and about 25. These definitions keep changing, but let's say about 25 in India, it is considered obesity. You're not going to start using this the moment you cross 25. But when you cross still higher, let's say 27, 30, and then you have mild obesity, moderate obesity. So you have different types. And then, as Dr. Mishra said, you can have clinical obesity or you can have without clinical obesity. Once you have clinical obesity, you mentioned all those symptoms of obesity. That means the comorbidities along with obesity are also set in. That's when you start considering. So either if the obesity is too much, let's say the BMI is 40 or 45, very difficult to get it down with diet and exercise at that particular point. And earlier days, we would have been considering bariatric surgery for these people because even their lifespan can get affected if you have very severe degrees of obesity. Today, there is hope. We're not saying that bariatric surgery is over now, but many of the patients who might have needed bariatric surgery, today, for the first time, we have a drug, and very soon the other drugs will also come in.
Yeah, sorry to interrupt here. So you were saying something, but can we then say that probably once these obesity drugs are there, Mounjaro is already there in India, there would probably in the coming times there would be no need for bariatric surgeries at all because people will have the option of.
Yeah, that's not really true. A few people can probably, who we would have considered bariatric surgery, would probably not need it, and they might result in this. I don't think they are actually competitive to each other, but they're probably supplementary to each other. For example, let me give you an example. If there are very severe, extreme degrees of obesity, let's say the BMI is 50 or 55, you see patients like that. Even Mounjaro or any of these drugs only have that much effect that they can do. So there is still a scope. So probably pushing the needle a little bit as far as the bariatric surgery is concerned. Second, to prepare a patient for bariatric surgery, the higher they are in the BMI, the risk is also higher. So if you use these drugs and bring it down somewhat, then when you do the surgery, it becomes a little easier. Third is, after the bariatric surgery, many people regain weight. It's not that after bariatric surgery, nobody regains weight. Sometimes the diabetes also comes back, the weight also comes back. So as a supplement after bariatric surgery also, it may be needed. So they're probably supplementary to each other, and the physician or the surgeon who's treating the patient has to decide which is for which particular patient.
Okay. So, Dr. Mishra, there are also very significant safety concerns around these class of medicines that we have known about, gastrointestinal symptoms and other serious illnesses, that side effects that can some patients get affected with. So what is there to be kept in mind once the patients need to be on this drug? What is your advice to patients?
Yeah, those safety concerns are, in fact, just supplementing what Dr. Mohan has said. If there is a significant safety concern, then these drugs or similar drugs cannot be used, and then bariatric surgery becomes a stronger option.
Can you elaborate on what exactly the safety concerns
are? I'll come to that. So the most common adverse effects of these drugs are the intestine related, and these are nausea, vomiting, diarrhea sometimes. So some people are unable to tolerate this. They have major problems, and they will have to stop the drug, or they stop the drug themselves. We prime them up before starting the therapy, and we tell them the first 2 to 3 weeks or maybe 4 weeks, or once we are escalating the dose of the drug, they may have some problem, and later on it will settle down, and you may not have so many symptoms related to intestine. The problem is that many of these people are on multiple other drugs, and some of the drugs are also irritating to the stomach. So combined together, around in our experience with the semaglutide, we have a good amount of experience, and the previous injectable GLP-1 receptor analog, around 10 to 15% of patients either leave it, or we tell them that you have to stop this medication. So that is the primary concern. And that is, if a patient is primed properly, if diet is slightly altered, we give them some drugs for vomiting, nausea, etc. then most of them will manage that. That is number one concern. Number two, or other concerns are not as frequent. They are they occur in less than 5% of the people,
Mhm.
and in large trials, sometimes these adverse effects are not even seen. For example, inflammation of the pancreas is one adverse effect which has been uh, which has been talked about. But some of the large trials have not shown, for example, some of the trials of tirzepatide have not shown that the pancreatitis is of a significant concern. Similarly, in recently there have been concerns about intestinal sluggishness or so-called intestinal paralysis, which is entirely a wrong term, but let's call it intestinal sluggishness. That may occur in some of the people with the long-standing diabetes who already have sluggish intestine, and this one of the ways it acts is through sluggishness of intestine, or intestinal movements are less, and that's how the feeling of fullness is there in when the people receive these drugs. So, in those people who already have sluggish intestine, they may cause further sluggishness. However, in my experience, and maybe Dr. Mohan can add subsequently, I have not seen a single case like this.
Okay.
In those people who have family history of thyroid cancer, a particular type of thyroid cancer, we do not give these drugs because in animal models, but not humans, it has been seen that a particular type of thyroid cancer is increased with the use of these drugs. I have not seen a single case of any thyroid tumor occurring with these drugs in our in practice, but of course, large number of people must be treated to know what is the different kind of side effects. So these are some of the side effects which we explain to the patient, uh, and I can tell you once we explain to the patient, 99% of the patients will accept these drugs. The only other concern which is there in patient's mind is cost. Now, cost, say, for example, semaglutide, 10,000 per month, or tirzepatide at the dose of 5 milligrams, 17,000 rupees per month, uh, is can be prohibitive in a patient who's a middle class or belongs to a lower middle class. And so we always inform them this is the price. However, long term, once you lose weight and also have lowering of your blood sugar, heart protection, and kidney protection, all round protection with these drugs, you'll be better off. In fact, later on, your expenditure in any of these complications will be due to any of these complications will be less.
We'll
But
come
then
to the first part later, but there is one related question after the side effect part. So I'm really sorry, I'll have to ask this. Uh, I want to understand one another concern that many people have expressed is that once they are off medication, they tend to put on the weight again. Is that correct? If yes, people who start on these kind of medications, will they be needed, required to be on these drugs for the rest of their lives? Is that how it works,
see,
Doctor?
there are two aspects to it. For me. This is we are not talking about side effect. This is something about the future once we give the drug and then stop it. So that is what we are talking about. Now, if we give a drug, say for example 1 year, and a patient loses, for example, 15 kg of weight, patient starts walking, the quality of life is better, the blood sugar medications are off, psychologically the patient is much better, then we may think of tapering down or stopping the drug. Keeping the patient informed that, like any modality, whether it's a diet, whether there's any other weight loss drug, there are plenty of other weight loss drugs, or whether bariatric surgery, you cannot do without enough diet and exercise when we are tapering off the drug. In fact, you have to probably augment the effort, double your efforts as far as these two are concerned. The trials have shown that weight gain will occur. Some patient more than the other people. However,
Mhm.
it never reaches the same initial weight when the patient started on the drug subsequently. So patient is better off even after stopping the drug. However, he has to toil more as far as exercise is concerned, do more as far as diet is concerned.
So it's possible to, you're saying that taper off and then probably eventually stop the medication at some point, and it's not
For
really
sure,
absolutely
it is
required.
possible. It is
That is how
possible. For example, let me give you a brief example. A patient who's diabetic, newly diagnosed diabetic with a BMI of 40, as Mohan was saying, uh, and has a fatty liver, has a high cholesterol, is giving this drug. 1 year down the line, patient loses 20 kg of weight, 15 to 20 kg.
Mhm.
Diabetes is reversed. Diabetes is reversed. And we may stop all drugs to see the patient is clearly in the reversed mode or so-called remission of diabetes.
Mhm.
This is what we should do ideally, provided patient loses this much of weight, which
Yeah.
may not be possible in every patient. So be careful in interpreting the weight loss. The weight loss may vary from 3 to 5 kg to 15 to 20 kg.
Yeah.
And people who have certain drugs like insulin may have trouble in losing weight, or
Mhm.
may uncontrolled thyroid may have trouble in losing weight. So I'll always tell my patient that 95% of the people will lose weight, 5% still will not lose enough weight on this drug. So this is how we begin the conversation on Mounjaro.
Yeah, that's a very useful information again. So, coming back to the costs that you mentioned, Dr. Mishra, I would like Dr. Mohan to also take up this question now. So, one of the things that's being said about this drug by Eli Lilly, which during the launch of the drug, was that this will be available at 14,000 to 17,000 per month for 2.5 mg and 5 mg vial respectively, and but some endocrinologists I was speaking with, they have expressed concerns that at these doses strength, probably the people who take the drug won't really get the desired result. So they'll eventually need to titrate their doses up, and if they titrate their doses up, it eventually means raising the cost of the drug monthly treatment that they would be on. So how do you address those concerns? And also, do you really think that this is going to be like Dr. Mishra said, that a large chunk of our population has a problem in accessing the treatment, right kind of healthcare, as we know is a reality in India? So what percentage of people who actually might need the treatment may be in a position to access it as of now? Yeah, Dr.
Yeah,
Mohan.
I think Dr. Mishra already explained that the cost can be around, and you also said around 17,000 rupees for a 5 milligram per week dose.
Mhm.
Now, in India, in general, not just for this, but in general, we tend to use slightly lower doses of drugs than, for example, a much bigger built Westerner. The American doses which they use is usually a little higher. So, from that angle, although up to 15 milligrams of terzepatide has been used in trials, not all our patients are going to need that dose. Even at 2.5, and even in the trials that we have seen, even at 5 milligrams, the dose is the effect is quite good. And of course, at 10 and 15, it is much better. No getting away from that because there is a dose response curve. But at 5 milligrams, the result is not bad at all. In fact, it was matching that of semaglutide even at 5 milligrams. Now, the
Mhm.
second point is that from yes 2.5 to 5, 5 to 7.5 or 10, or as you go to 15, the dose will go up. But somebody who can afford, let's say, 17,000 rupees, if it goes up to 20,000 rupees, they are not going to flinch because, oh, it went up another 2,000. We can't. In the first case itself, even when you talk about 5,000, 10,000 rupees, there are people who cannot afford even metformin in our country. Okay. So India is a country where we have a bullock cart also, and we have people who own two jets and two jet planes, they own ships and so on. That's India. So if you at this stage, we are not talking about this drug being applicable for a Aam Aadmi walking on the road. May not be able to afford this drug unless we make it free, unless we bring in reimbursement, unless the insurance pays for it, or the government decides that we are going to give this for all obese people, because our Honorable Prime Minister, also spoke about obesity, but he also spoke about diet first, and cutting down oil and so on. So therefore, if such things come, then of course to everybody it will become so. Any new drug, any new method, anything which comes in, it's a little difficult to think of every Indian being able to afford a drug. So at this point, yes, those who are upper middle class and above can probably think of using the drug. The others will have to get either subsidies, or somebody will have to pay for it, or a corporate has to pay for it, or finally insurance or somebody has to come to pay for it. Having said that, I would like to make another point, that the same Mounjaro is not made in India, by the way. It is coming from the US. And the same Mounjaro in the United States costs about $1,000 to $1,500 per month, which means we are talking about a lakh of rupees or above, 1 to 1.2 lakhs of rupees for the same Mounjaro. Okay, but it's probably the same dose of the drug. So we are talking about something about one fourth or less of the cost, one sixth of the cost of what it is available in the US. And from that angle, I think we have to be happy that at least at this price, we are able to get it. Secondly, when the patent runs out, and this happens to all drugs, for example, semaglutide is probably going to go off patent next year, or at least by the year after that. So the moment it goes off patent, all Indian companies will now bring the drug. This has happened to empagliflozin recently. It happened to dapagliflozin. Every drug which goes off the patent, the price drops by 70%, 80%. So if we are able to get this drug without, once a patent goes away and other companies are able to produce it, then the cost will definitely come down dramatically, and many more people will be able to afford it. So there is no getting away from the fact that it is an expensive drug. We can be lucky that at least now you don't have to import it from there and bring it as people used to do it earlier, and it's available at much lower cost in India compared to many other countries. But having said that, it is still not within the reach of every common man with either obesity or diabetes.
True, true. So, Dr. Mishra, another problem that we have in India is a rampant over-the-counter sale of prescription drugs. In India, per se, we don't really have over-the-counter drugs, but we know that, you can just walk to a pharmacist and get any medicine that you want. In that a scenario, do you see the abuse and misuse of, the drug, particularly because now anybody who thinks they need to lose weight, and how we know that how some people can really be very, very touchy and sensitive and particular about losing weight. So now there is this option without probably though doctors like you, sir, clearly say that this has to be in the context of diet and lifestyle measures, but many people would want to just take the drug and lose weight, and people can just do that. So do you really see a risk of abuse and misuse of this drug?
It always happens, for me, always happens. Any drug. But it was happening more often when it was not available officially here. Before that, there was black market, and people were telling me that I can buy Mounjaro in any place in India. Of course, the cost was 40,000, 30,000, 40,000, something like that. And some people were getting from Dubai anyway, and nearby countries. So the self, buying the drug themselves and injecting themselves was also happening in some patient. I'll give you an example. One patient from Ahmedabad, a very wealthy person, came to me and says, somebody told me that, and he was taking Ozempic, that this drug is very good for weight loss. And I started taking it. There was a drugstore which gave me without any prescription, and I just looked at the dose and I started taking it. I examined him and found out that he has a very strong family history of thyroid cancer, and there was a small thyroid node also there. So this is the way the things may happen. That patient don't know when to use it, what side effects are there, how to counter those side effects, and so on. So this is not a drug to play around with. It's not like aspirin or you take Compiflam or something like that over the counter, and you can get away with it 99% of the time. Here is a drug which needs to be carefully taken after having uh, told the patient everything about the drug, and they should accept it. Yes, I'm going to start now because I have heard every two and uh, you know the pros and cons of this particular drug, uh, positive and negative point. However, your point is still taken that there might be some people who may take it over the counter. They may get into problem or they may not get into problem. But uh, whenever we give any interview, or Mohan or myself or any other diabetologist, the last but most important message we always give is that this drug has to be given under medical supervision, uh, after the patient understands all side effects. So this is the way we always tell them, and some messages have gone through the media and people like yourself, and people do understand. So I think one out of 100 people person may take over the counter, but 99% will still come to the doctor.
Yeah, that's a very key message, that even if you think Manjaro is a drug for you, do talk to your doctor before, going for it. Dr. Mohan, your last words on, you want to add something to this concern, this risk factor.
Yeah, absolutely, because but the chances of people taking such a costly drug, just going and to a pharmacy and give me something for, it's very unlikely, because even when they come to us, they think 100 times before they take. And one of the first questions, as they rightly ask, is how long should I take it? And it's a very difficult question to say, how long can you take it? How long should I take my BP tablet? How long should I take my other anti-diabetic drugs? How long should I take a statin? How long should I take, if you have a chronic arthritis for which you're taking a disease modifying drug, how long do you take it? Normally, they're for long periods of time. We don't use the word lifelong because many things happen in between. We might have to stop it for other reasons, or they may have achieved the weight loss, and then later on they might take it less often. For example, this is a weekly injection, but once they have reached a maintenance, weight keeps going down, 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 and then it plateaus off after some time. As long as the weight is dropping, they're very happy. The moment it reaches a plateau, they say it's not going down any further. That's it. So now what do I do? Do I stop it? So as Dr. Mishra said, there will be about 50% weight gain. Suppose 20 kilos they've lost, 10 kilos they may regain. So we'll have to tell them that. So one of the ways in which even the company is saying that we can do is reduce the frequency. For example, instead of once in a week, maybe once in a fortnight. So you're still getting some effect of the drug, but you're not completely gone off the drug. Even if you lose the effect, you may not lose 50% of the effect. You may lose 25% of the effect. So there are many ways in which it can be done. But the last thing we want is for people to just read something in the paper and then go and then take their own treatment. It's happening now because thanks to Google and internet and all that, people are becoming Google doctors, and their own Google University they follow. So they just think that, oh, why should I go to a doctor and pay his fees and I can get everything? They think that they're very wise, and so therefore they read everything about it. What they don't understand is there are many, many aspects of it which only a doctor. As far as the regulatory approval of this drug is concerned, our drug controller is also very, very careful. So the government has not let loose. They have said either an endocrinologist or a physician in practice who is looking after patients should only first start this. They've not even straight away released it to any Tom, Dick, and Harry to use it. Even among doctors, they've been very careful. They want to see the first effect of the first few thousand patients treated in India, because in case there is any side effect. See, there are certain drugs which will produce more effect or more side effects in Indians, for example. So they want to be careful about that. Once we get more comfort, maybe 1 year down the line, the government may also say, okay, now we are reasonably happy. Now others can also use the drug. When we are so careful about which doctor can prescribe, going to a pharmacist and then saying, give me the drug, or a pharmacist illegally selling it just to increase his revenue is not at all ethical, and it's not correct. It's not, the government will not accept such behavior. And we have to be very careful. It's at the risk of the patients if they do that.
Let's hope that doesn't happen. And thank you so much, Dr. Mohan and Dr. Mishra, for those insights. Really appreciate that both of you could be there with us today. Thank you so much.
Thank you.
you.